learning objectives, whether you're trying to teach or improve a knowledge base, you're trying to teach a skill, or you're trying to change an attitude. So simulation is used in the different fields of anesthesia. So for airway management is primarily a psychomotor skill, hence simulation training is a suitable way to teach such skills. So there are different simulators available now to teach airway management. And different airway management simulation workshops and courses focus on different aspects of airway management, including a comprehensive airway exam, how to set up an airway station, proper positioning, or opening up the airway, use of your airway adjuncts, bag mask ventilation, use of your laryngeal mask airway, and intubation. So when used for airway management training, simulation has been shown to have sustained learning outcomes, increased learner satisfaction, knowledge, technical skills, and improved patient outcomes compared with traditional learning strategies. So a study evaluated the effect of simulation-based training in fiber optic intubation and observed a positive learning effect regardless of the type of task trainer used. So in this study, they compared using just that box to teach fiber optic intubation as compared to a real mannequin or a mannequin simulator. And they found that the results were the same. The positive learning effect was the same. There was also a study that evaluated the effects of cricothyrotomy simulation on compliance with the difficult airway management algorithm and the technical skills of cricothyrotomy. So post-intervention tests done after simulation training showed an increase from 63% compliance pre-intervention to 100% compliance with the difficult airway algorithm. So there was also an improvement in duration, quality of cricothyrotomy, and a retention of skills when tested a year later. So Dr. Urshon mentioned that one of the findings in terms of morbidity and mortality was usually there is very low compliance or adherence with algorithms. No? So simulation studies have shown that simulation will help your trainees or anesthesiologists be more compliant with these algorithms. In a meta-analysis of advanced airway management simulation training by Kennedy et al., simulation studies compared with no intervention showed a benefit in improving knowledge and skills when compared with non-simulation interventions. So those who had simulation-based training showed increased learner satisfaction and again, improved skills and patient outcomes. So difficult airway management is one of the primary challenges and most important patient safety issue in the practice of anesthesiology. It is the leading cause of death and legal ramifications. And while airway management skills are primarily, again, a psychomotor skill, they tend to require application of complex procedural techniques, often under time constraints and clinically critical situations in the real clinical setting. So simulation experiences allow practitioners the opportunity to practice and maintain and frequently apply difficult airway management skills and algorithms. So the use of ultrasonography in regional anesthesia has gained widespread popularity over the past decades. Simulation is an effective tool proven to help anesthesiology residents get comfortable with the use of ultrasound in regional anesthetic techniques. So a study showed that simulation considerably improved the knowledge of ultrasound anatomy but did not show significance in the live scanning skills. Another study observed that simulation training on needling and proper hand-eye coordination improved subsequent clinical block success. In regional anesthesia, it is also used to teach management of block complications such as local anesthesia systemic toxicity. And they have found that residents who go through simulation for going through the last algorithm adhered more to the algorithm when it happened. So there are several broad uses of simulation of obstetric anesthesia, including improvement of technical skills, non-technical or teamwork skills, individual clinical competence, and the safety of the clinical environment. So we already have different task trainers made specifically for obstetric anesthesia that can teach technical skills such as performing urachal blocks. So the volume of cesarean sections done under general anesthesia have significantly diminished over the years. Simulation is used to fill this gap in training of residents. So a study showed that residents exposed to repeated simulation-based training to perform GA for emergent cesarean sections showed a measurable improvement in performance, and they noted that the performance scores remained the same at the same level 8 months later, showing that long-term retention of simulation acquired skills. Obstetric crises are the ideal platform for teamwork exercises because of the acuity of the medical conditions, the interplay of different medical personnel involved, and the importance of timely communication. So again, simulation, several authors studied the role of simulation in refining teamwork skills during crisis management, and they found that simulated obstetric emergency was perceived positively by the participants, and it caused a measurable performance in the simulated environment. However, further study should be made to know if it translates to actual clinical practice. In terms of cardiovascular anesthesia, as cardiothoracic and vascular procedures become more complex due to technological and research advances, cardiothoracic and vascular anesthesia trainees have to learn more intricate and complex skills. So simulation allows them to repeatedly to practice such skills and manage complex cases in a low-stress environment. There are simulators and task trainers available to practice procedures such as central venous line cannulation, your transesophageal echocardiogram, and fiber optic bronchoscopy. So simulation-based education has been incorporated in the adult cardiac life support courses in the form of computer simulation to identify rhythms. And of course, we all know the megacode to simulate a cardiac event. Simulation has also found its way in pediatric anesthesia. We have task trainers to simulate pediatric area management. We even have a mannequin for your periobun dedicated to practice intubating your periobun baby. We also simulate the use of cognitive aids in pediatric anesthesia like your Braslow tape. We do modified rapid sequence induction. In PGH, we've done 2 simulations prior to separation of conjoined twins. And of course, we also simulate your pediatric anesthesia pediatric advanced life support. We go through critical events and we make residents go through the algorithms for these pediatric anesthesia critical events. So using a critical incident analysis to study the occurrence of errors and mishaps in anesthesia, they found that human error was a factor in 70% of critical events. So recently, there has been a lot of interest in using simulation to teach and evaluate anesthesia non-technical skills. Both our previous speakers have talked about the importance of our non-technical skills in patient safety. These skills are not acquired through routine clinical training, but are important for an anesthesiologist to learn. So, as was mentioned, non-technical skills are the cognitive, social, and personal resource skills that complement technical skills and contribute to safe and efficient task performance. So again, deficiencies in non-technical skills may increase the risk of error, which in turn increase the risk of an adverse event or clinically relevant adverse outcomes. So simulation training is a valuable and effective tool for both to teach both technical and non-technical skills. Behavior-based crisis resource management. Because crisis conditions are low incidence events in clinical practice, both technical and non-technical skills required for managing these crises are unlikely to have been rehearsed, practiced, or experienced in the months or even years preceding the requirement for emergent application of clinical skills. So decay of skills learned during training but not regularly incorporated into clinical practice is inevitable. So simulation provides the advantage of a safe environment for crisis management training and is a lifelong learning strategy to manage uncommonly encountered clinical crises. Another important application of simulation today that has impacted patient safety is in the realm of interdisciplinary operating room training. So anesthetists, again, work